So thank you. It really is a pleasure to be here. And this is very new to me because I've never spoken to a group dealing with glioblastoma before. So this has been a tremendous challenge. I'm very happy to be here for a number of reasons. Number one, I love Maden. You can't help but like him and his family. Not only are they outstanding in what they do, but they have taken on a mission, which is a very important mission, which all of you relate to, unfortunately, many in a very personal way. The second is that it enables me to talk. I haven't talked before to a group like this about personalized medicine, the evolution of personalized medicine, why it's so important conceptually. But the third, and maybe the most important, is as I started thinking about what I was going to talk to you about, it became apparent to me that I couldn't come to you with a solution based on the way we currently look at things. It requires a new way of conceiving, of dealing with a rapidly evolving lethal disease. So what it made me understand is that with personalized medicine and precision medicine, as far as it's taken us up until this time, we need to go to another step. So you could say, oh shucks, darn, what we have put together, the framework has met a limitation. But anybody who is a scientist or a physician, or any of you say, wait a minute, we don't stop there. What do we need to do going from here to get to that next phase? And I know that all of us, one of the things I'm most proud of during the time that I was Chancellor for Health Affairs is that we created the Brain Tumor Institute. Henry Friedman, Alan Friedman, and the comment that we had around that is that at Duke there is hope, because hope drives action, and it drives an anticipation that something can be accomplished. So what this talk has forced me to do is to rethink the concepts that we had developed over the last 20 years and come up with the conclusion that it's necessary but not sufficient. We need to go to another step. And what I'm going to talk to you about today, towards the latter part of the talk, is that we actually have the opportunity to do it. And I couldn't have said that to you 5 years ago, because I think that there is an evolution that I will talk about very briefly that enables us to do it, but it's going to take the coordinated effort of people like you, Duke. I hope we could get it deeply involved, and all people like yourself who point out that the consequences of everything that we do relate to people, and we need to understand that. So let me start, and I will be showing, I had a PowerPoint, and it may, I hope it's not too small and hard to see, but I will talk through it. It kind of leads me through where I want to go. But I want to go very briefly to a history of healthcare. Now, it's interesting that at the earliest recorded history in any aggregated civilized group, there was always a concept of healthcare. And very frequently there was a shaman, there was an entity, there was some focus on trying to enhance healthcare. But up until the late 1800s, 1900s, healthcare was metaphysical. It was not based on any scientific principles. It was based on concepts that really make no sense, that the body has 4 humors, or it has different chakras, and that the way we treat it is by bloodletting or various other things, which certainly they're beautiful and may be meaningful, but they really have no clinical impact. So as I started when I was Chancellor for Health Affairs, I was responsible for a healthcare system that we had just developed, the first integrated healthcare system, and we had 2 million visits one year. It was probably the late 90s. And I was going to present to the board of Duke how the health system was doing. So I just kind of looked at, I remember asking my people, we had 2 million visits. I want to know something about who are these people? Who's coming to Duke and why are they coming? And what was astounding is that 80–90% were individuals that were coming to Duke because they had an episode of a chronic disease. In other words, they were already ill. They had a bad episode, they needed to be treated. We would treat them, do the best, and send them back home. And we were considered one of the best in the country. And that struck me as being totally inadequate. It's looking backwards. It was looking backwards. Something occurred and we tried to fix it. As I said, before the early 1900s, there was no scientific basis of disease. But a number of things happen, aggregated things happen. And this is an important point, the aggregation of new capabilities that give you the ability to do something you never did before. So you had germ theory, Pasteur, other very famous people. Probably the most important thing, tuberculosis, which was at that time the cancer of the time, consumption. Nobody knew what it was. Finding out that it's a specific microbacterium, specific bug that you could isolate. This is the cause of tuberculosis. So it started getting people to think, oh my God, if there is a disease, there's a cause. And if we identify the cause, we could find it and fix it. So the aggregation of germ theory, chemistry, physiology, pathology, and physics came up with a model of care that allowed the understanding of a disease. And again, that was the concept that founded medicine. And it's very much related to identifying a disease, finding it, and fixing it. Over the subsequent period of time, let's say 100 years, and I started thinking about this in the late 90s, saying there's something wrong with the current system. I mean, finding it and fixing it is important, but why don't we predict it? I mean, why don't we start anticipating a problem before it occurs? And lo and behold, there were a whole bunch of aggregation of scientific capabilities that were enabling a whole new way of looking at this problem about health and disease. It was profound. It was an epiphany to me that genomics, multi-omics, the ability to measure not only the genes, but what the genes are producing, and then digital technologies, behavioral psychology, et cetera, came up with the idea that we really need to think about healthcare differently. Rather than finding it and fixing it alone, we ought to be able to predict it and personalize it. So we came up with this concept, early 2000s, started writing about it, understanding health and disease with precision. And that was the foundational basis of personalized healthcare. Next slide. Now, if you talk about all of us, we're sitting right here. What are we? What are we a product of? We're this oversimplification, but it's worth thinking about. We're a product of what we inherit, everything that we inherit. But once you inherit that, it is modified over time in utero. Once the egg is fertilized, you have a new set of DNA, you have your genetics, but then everything else is dependent on the environment and all the things that happen to it, and then when you become a living human being, all the things that you do. So that health and disease, even as powerful as genetics is, it's genetics, but it's also everything that you're exposed to, either from outside forces or what you do yourself. And over time, that creates either health or disease. Now, this is a tremendous simplification, but it turns out to be a beautiful framework to say, well, if we buy this, we could think of a whole new way of delivering healthcare. We could start looking at any individual at a point and try to understand where they are, and then what we need to think about is not only the problems that they have now, but what might they develop, and if they have a problem now, what might it evolve into, and how could we intervene earlier and more specifically? So that was a whole new way of thinking about health. And the way I described it, that we need to think about healthcare differently than before. If you think about health and life, just imagine this. This is time. And then this is, let's say, a disease. You could pick any given disease, but or it could even be related to health or the loss of health over time. So you start out with your genome, and then over time you have the exposome, what you do, what you're exposed to, and then something may happen. You may develop a disease. You know, here you could think of glioblastoma, but you could think of type 2 diabetes. So you could think of almost anything, and the time frame is different. But you start off basically with risk, your genetic risk, and then all the things that relate to the environment, and then you have a phase with the development of the disease. So this was, again, the initial concept. In the next slide, what was striking to me, overseeing this, one of the most successful healthcare systems in the world, virtually everything that we did was over here. I mean, that's shocking. And unfortunately, this is still where it is. That almost everything that we're doing is reacting rather than thinking proactively. Next slide. So again, the concepts flow pretty easy once you think about this. You know, what can we do about it? How do we change healthcare? How do we make it different? Well, number one, to recognize we want to do it differently. But then, even if we don't have the highly sophisticated capabilities, as long as we have clinicians and people thinking about this, we try to define the earliest clinical detection, you know, when something starts. So you make people more aware of initiating factors and the change from health to diseases. But then earliest molecular detection, which would be all the different diagnostic tests, and then genomic risk, and that is the individual's genome. So that again creates a new conceptual model for healthcare. But then taking it a step further, next slide, and this may be a little bit too detailed, but thinking about, okay, how do we do something about it? You know, we have this concept, how are we going to change how we practice care? Well, it really defines a kind of a layout, an architecture for a new model of healthcare, which is personalized medicine. It has other names, but basically personalized medicine. And that the components of it is you try to quantify an individual's risk, you know, depending on whenever they enter into the system, at that time, to try to understand and quantify their risk, but it really becomes proactive in that you're trying to identify risks based on the individual, identify them, note them, and say, what can you do to prevent them? Or if you have things that you want to enhance an individual's health, what are the things that you need to do to enhance it? So it becomes planned rather than reactive. So initially, if you think about somebody's lifetime or before they develop a disease, it would be nice if we knew baseline risk, if we were able to see what are the factors that are going from that risk and making it become active or dynamic, refine risk prediction, monitor, define disease, personalized therapy, and then you manage the disease. But core to this whole concept is going away from saying, when you go to see the doctor, what's wrong with you, and let's see if we could fix it. You always do that, but to say, given who you are, where you are now, how do we try to plan for your maximum health and minimum disease? So it came to this foundational element, which, even though I'm going to talk about new ways of looking at things, the idea of having a personal plan is essential to the future now, as well as even thinking of new concepts. So this was really, we started talking about this and publishing probably 2003, 2004. And it really created a new way of thinking about healthcare, but unfortunately, conceptually, it was more and more accepted, but practically speaking, the healthcare system has not responded in any way that is embracing this the way it should be. Next slide. So, the nature of the change. And everything that I'm saying here is definitely related to the glioblastoma problem. And I'm going to get into it in a little bit more detail. The way that we have done it before, it's reactive. I mean, if you think in your own mind, your own experience, reactive. The care is sporadic in that it's not a continual flow of care. You have this. It's sporadic. And this is related less to the problem we're talking about today, but it's focused on disease rather than prevention or mitigation of disease. Find it and fix it with a single set, limited set of tools, very heavily directed by the physician. You know, the patient's kind of left out of the equation. And I'm just speaking to, people this morning, I realize how important that is. And very dogmatic. Where what we are moving towards, predictive, proactive, continuity of care, understanding the dynamics and minimizing it, and then, again, more broadly, disease prevention, targeted therapies when you need it, but we'll talk a little bit more about that, but it involves not only the healthcare system, but the individual and partnerships and communities. In other words, it takes a village for this to work. So that is the model of healthcare that we envisioned and continue to work to try to effectuate. And there is a lot of progress. We don't have time to talk about it. As a matter of fact, I'm probably talking too long already. Okay, so next slide. This is what I think is very important to realize. When I talked about all the new capabilities, and that's before, right now, that's before what's happening, which I'll talk about towards the next few minutes or so. We could move to a degree of sophistication that's far greater than we ever envisioned when we first got started. Because once you can analyze an individual, once you could evaluate an individual, incorporating their genomics, and when I say multi-omics, that means that all the products of the gene, the proteins, the metabolites, so you could see in dynamic action what the gene is doing. The clinical evaluation, how the individual is doing, the nature of their exposures, their behaviors, which is very, very important, and social determinants of health. So you could, around each individual, you could think of yourself being surrounded by this vast data cloud that's following you all along, and as every day, every moment, that data cloud changes a little bit. But that data cloud is you, your health, and if we're going to do something about it, to be able to analyze it and act on that. This is the big black box, mystery box. And when I created this, which was probably about 5-6 years ago, we already started having the early development of machine learning and artificial intelligence, but it was infantile compared to where we are now. But it enables you to take a group of individuals and say, you may be here, there, we're all different. But we could start identifying the individual in terms of their health characteristics. So this becomes a powerful new way of looking at health and disease. Next slide. And the concept that I had been thinking about and giving this talk, thank you, has forced me to really think about it more and more and more and more, is that what we need for health is something akin to what you do every day when you get into your car. You're wherever you are. This morning I started somewhere 3 miles from here. I punch in 701 Main Street and boom, it tells me how to get there. And so that's the information. It has all this information about this place, that place, all the geographics and such. So I could go directly here. But the idea is I need a plan. What I wanted to do is go from our home to 701 Main Street, the Chesterfield building. And it tells me this way, I could go that way. I could have gone, instead of taking 15501, I could have gone on Irwin Road, whatever. But you get the drift. Okay, so that's conceptually where we're going, and that's the purpose of the personal health plan. Okay, now the other thing that comes from this, and this is where it's most relevant, is precision therapy. Because the same concept that I talked about human health fits with the concept of the development of any disease such as glioblastoma. But glioblastoma is, as best I could tell, probably the most enigmatic, challenging problem that I'm aware of in healthcare, because of the lethality, the clonal variation. There are so many things, I won't go into the details, but it is like, who designed this thing? I mean, it is unbelievable how difficult it is. But the idea that you do a evaluation, a careful evaluation, and then you keep on refining the therapeutic approach based on what you learned, biomarkers, genetic analysis, all the things that they're doing here. And then you come up with a therapy, and then you treat. And then if things change or progress in this, you treat again. So that, this actually happened. I mean, because you're here. I mean, you build it. It's fantastic. What I would say, as it relates to glioblastoma, it's necessary. You have to think this way. You have to think this way. But it's not sufficient. It's necessary, but not sufficient. And I'll spend the last few minutes showing you why and how. Next slide. So, where we were up until 2000, pre-science, pathophysiology of disease, personalized medicine, precision medicine started coming about, roughly 15 years ago. And now, for the first time, people are thinking about how do we start changing the healthcare system. That's where. Now, the next slide, and this is probably the most important. Glioblastoma challenge. Unfortunately, many of you have lived with this. Lethality. The heterogeneity of the tumor. You're not dealing with one tumor, 6, 7 different tumors that could change clothes, and it's unbelievable. The ability for the tumor to select itself, to adapt rapidly and progress. Current precision therapy is inadequate, which then leads to recurrence. Next slide. Okay, so this is the take-home message, and the details are less important than the concept. 2026. In addition to everything that we had before, we now are developing these mass data sets of individuals, different places, all the things that we need to know, massive amounts of data about the individual and all the factors that are related to the disease. So we were able to assemble the data that we need to have better understanding. You know, what is the cause of this instability and clonal selection in glioblastoma? And everything that I've looked at really doesn't give me a pinpoint of saying, you know, this is really the basic defect that I could find it and fix it. It's, for whatever reason, till now, it's more complicated than that. So the old ways of doing it are just not working for this. So you need to have a dynamic learning platform. You'll need precision therapeutics, but they need to be based on this information. But this is where we're able to go from 20 to where we are now. The true initial development of AI and agentic systems that truly can analyze and enable dynamic prediction. And when you have dynamic prediction, you'll be able to track it. So you make a conclusion as to the best way to do something, but rather than waiting for months and months to see if something works or not in a disease that has a time frame of, you know, a year or so, you could have much more rapid dynamic reaction. So near real-time tracking, and then clinical decision augmentation, so that your decisions are augmented by this new way of being able to navigate information. So what this gave me the profound understanding, and again, thank you, is that what we had done before needs to go to the next step. And amazingly enough, I think we have an idea of what that is. And that is to take everything that we had and say that is good, but we need to add this dynamic, continuous learning layer to it so that we could react quickly. In other words, that rather than having a health plan, just a health plan, to have something that's more dynamic. You see that, you know, I was coming here and they said, Main Street is blocked. Okay, well that's not on my GPS. So, you know, how do you adapt to that? So we need to be able to do that. So we need to go from static to dynamic navigation with precision. Next slide. Okay, now this, if you ever want to look at the slides, you could do this home. But I just want to point out to you that we could actually envision how to do this. You know, the things that we need to be looking at. The development of a digital twin, which is absolutely going to be critically important to this, because you develop a dynamic computer model of everything related to the individual and their disease, and then rather than waiting 3 months to see what happens, you plug that in and see everything that you know, how is it going to evolve. It's a whole new way of thinking. It's still early. But even at Duke, Modern, as you know, we have people who are working on this. And then you develop a navigational engine to be able to process all of this, and then you have a dynamic personal plan. Next slide. So currently, with glioblastoma, there's a diagnosis, molecular profiling, treatment decision therapy, weeks and months. What you are doing here, you're going to refine this and revolutionize this. And it's going to be a heck of a lot better. But we need to do this one other additional thing. This is a mission to take this, which is the current way, weeks, months, progression, repeat cycle, and use all these capabilities, these navigational tools, to come up with a new model. Next slide. And this new model is going to be continuous data integration. We need to be able to be looking at things dynamically. They may need to be sensors or other biomarkers. We need to have a digital twin and a navigational engine, multiple adaptive care pathways, and dynamic adaptive therapy. So we need to go from the current therapy, which is as precise as it could be given what we know at this moment, knowing that we're dealing with something that's changing rapidly, and be able to put in that dynamic. And this is what, give you some hope, which you should have. This is at Duke. I'm working with a person who is interested in digital twins, and if you haven't learned more about it, I suggest that you all look into it. But a digital twin is essentially a model of you. Everything we know about that data cloud, that is you. And then with that digital model, you say, okay, with this data cloud, what happens if we do this? And then everything changes. And so you could predict with that individual's digital twin what is going to be the evolution, what's going to work, what's not going to work. And there is a digital twin model that is being worked on at Duke, Amanda Randall's. And this is a paper that she published. Next slide. So I'm going to end essentially with this. So we're going to be moving away from the precision glioblastoma care now, which is the best that there is. A heck of a lot better than ever, and I think the innovation here is going to enhance this. But if we combine this with this dynamic digital twin, real-time virtual model of tumor biology patient, you have a dynamic feedback loop so that the therapies, rather than try this and wait 3 months, try that, wait 3 months, you could dynamically change it based on what the tumor is doing and continuously adopt the pathway that's best for that individual. Next slide. So, what we need to do, and this caused me to modify my slides, you can see I did this myself, so it's not good at all, that we're going here and I saw that Main Street is blocked. I have to do something else, so I need to have the ability to dynamically change. The personal health plan is not enough because the idea is you create the plan and you run with it. You need to create a plan and you continuously adopt it depending on the needs of the time. Next slide. So my prediction, and thank you for inviting me to do this, is that the next era is going to be health navigation. We'll give it a better name, but it's going to be a dynamic, personalized healthcare. Thank you very much.